Broadcast is now starting. All attendees are in listen-only mode.
Welcome. My name is Ginny Cover. I'm part of the New York Tri-State Support Group. This spring, we had Dr. Tracy Prout provide an excellent presentation on strategies for coping. I just lost my screen, just a moment. There we go. Strategies for coping with disruptive behavior, particularly behavioral outbursts due to the anxiety that so many children and adults with X and Y variations have. Tracy is an assistant professor of psychology at the Ferkauf Graduate School of Psychology at Yeshiva University. She teaches courses on child and adolescent psychotherapy in the school clinical combined doctoral program and supervises graduate students, as well as leading the psychodynamic psychotherapy lab. She's a principal investigator for several studies related to regulation focused psychotherapy for children that emphasizes the role of emotional regulation in disruptive behaviors. She's also the parent of a child with XYY. The way that we handle questions for the webinars is that we ask that you type them into the question box on the lower right-hand corner of your screen. If you're listening by phone, you can send the questions to us at info@genetic.org. That's info@genetic.org. The questions should be general, and they can't identify your child or yourself specifically because of confidentiality issues. We'll answer as many questions as we have time for. Tracy?
Okay, great. Thanks, Ginny, for that really nice introduction. I'm really excited to speak with all of you tonight. I'm just going to go ahead and dive right in. Here's a little overview of what I'm going to cover tonight. I'm going to talk a little bit about disruptive behaviors and how emotion regulation factors into that. And I'll talk about some behavioral treatment approaches for disruptive behavior problems. And then I'm going to talk more specifically about emotion regulation and different types of emotion regulation, and specifically as that relates to the XY variables. And then I'll speak more specifically about some more emotion-focused approaches, and in particular, regulation-focused psychotherapy for children, which, as Ginny mentioned, is the work that I do. While the talk is going to focus on XY variations, you can also, I think, get a lot for siblings or other people in your life who maybe don't have one of these variations. So hopefully the information will be both specific and broad to apply to a range of people. So this is my son. Sometimes well-regulated, sometimes not. Don't worry about that picture over on the right. This was, his dad was not pouring his milk fast enough. That was what provoked that. So even before Urban was diagnosed with XYY, I was already doing this work in emotion regulation research and clinical practice. But of course, in learning more about the XY variations, I became a lot more interested and invested in how this type of work can apply to kids with these variations. So that's part of the personal aspect of what I'm going to talk about tonight. So I want to start with a vignette that I'm actually going to read quickly, and I imagine that this will be familiar to some of you, this kind of a scene. So mother says to me, we were driving home after a lovely time at the beach, and I said to my son, look at that beautiful sunset. Suddenly he yelled at me, stop trying to control me, Mom. I hate you. I couldn't believe it. We'd had such a nice day, and I was just trying to share a special moment with him. I got so angry, and I started lecturing. He answered back, shut up. You're being so mean. And as usual, I couldn't control myself. It's been years of this. And I told him, you're totally selfish and rude, and I'm never taking you back to the beach again. He answered back, I hate you, and kept screaming that for the rest of the car ride. What happened next? I took some deep breaths, we got home, and I went inside. I tried to forget about it, we didn't talk, and I felt really embarrassed that I'd lost control. I let him provoke me so easily. Every time I tell myself I'm going to respond differently and that I won't overreact, I know the right things to say, and it's all so predictable. If I lose it, he will lose it. If I stay calm, there's a chance we can have a real conversation. So I imagine that some of you can see yourselves reflected or your kids reflected in this vignette. Here's a sort of annotated version. You know, in the red you can see, you know, where the mom is doing her own form of emotion regulation or is getting really emotionally dysregulated. And the blue is highlighting, you know, her son and his efforts to control his feelings or not. And I think what I want to point out is what happens when they get home, right? There's not really anything that's processed. There are some good efforts made to try and contain and suppress the feelings that mom is having. And that is protective in some ways, but there's a real gap between what mom knows, right? What she knows she could do or what she could say and what she's really able to do in those really dysregulated moments. And so some of what I want to highlight today is how can we bridge that gap a little bit? How can we feel a little bit less out of control in these moments? And, you know, like the title of the talk, how to keep your cool, so that we can have more adaptive interactions in the future. So disruptive behavior problems in general, we hear this from parents in our research lab a lot. I love my child, but I don't really like him, or I don't like him most of the time. And that's a common experience for parents when they're facing any type of disruptive behavior, and specifically when the behaviors persist or are quite intense over time. So the prevalence of all disruptive behavior problems in children is pretty high. You can see the rates here for the community and for clinical samples. And we know that these disorders are costly to the healthcare system overall. So in fact, disruptive behavior problems account for greater expenditure in the healthcare system than pediatric asthma and diabetes combined. And that's through medication, psychotherapy, inpatient admissions, outpatient visits, other things that we do to try and manage these problems. And we know that disruptive behavior problems like oppositional defiant disorder, like ADHD, conduct disorder, these things have a real and lasting impact in a negative way on kids and families. So kids have a harder time learning, they have a harder time with social skills and functioning in the family. We know that kids who present with these problems when they're young, they're less likely to have someone later in life who would recommend them for a job. They're less likely to have success in love and at work. And so, of course, we want to intervene early and try and prevent some of those longitudinal problems across the lifespan. So in psychiatry, we have kind of this false dichotomy. We talk about externalizing problems and internalizing problems. So the externalizing problems, just what it sounds like, where you see the symptoms on the outside, right? The kids are explosive, they're irritable, they're angry. And then you have kids who we call internalizers. They turn inward. So their symptoms present more like anxiety and depression. And I know from the talk I gave in the spring with the New York support group, and also a conversation I was having earlier with Ginny, right? It's a common experience that we see in kids, the externalizing, but we know from the research and from our own clinical experience and our experience as parents that there's a huge overlap in these two kind of disparate categories. There's really not such a thing as a kid who's only an externalizer, only an internalizer. A lot of times the disruptive behavior problems emerge because there is some kind of underlying anxiety or depression or difficulty regulating complex emotions. So today we'll talk a little bit more about what that looks like and how to address it. So externalizing disorders are quite prevalent in the community and in clinical samples, but they are highly prevalent among kids with XY variations and also adults. So we know that Klinefelter boys and boys with XYY are at a much greater risk for ADHD, ODD, and overall externalizing problems, and that's from Judith Ross's research. There's some older research that suggests that as boys with Klinefelter's age, they tend to actually present with slightly more internalizing symptoms, some social anxiety and social withdrawal, particularly when dealing with conflict. Just to keep in mind that these things are really complex and they change over time. It's also very complicated to do this kind of research. So we're always kind of talking about averages. You know, as you think about your own kid, you might think, well, that's not really true. Or you think about yourself, you know, I have Klinefelter's, but that doesn't describe me. fair enough. There are always going to be, you know, many people who don't fall within that average of what we find in research. We know that girls with trisomy X are also more likely to experience ADHD and mood problems, so externalizing and internalizing. And basically all of the different XY variations are at increased risk for different types of maladaptive behaviors. Just to give you some specific data on ADHD, these are the increased risk rates. So for example, the Klinefelter samples appear to be somewhere from 36 to 63% more at risk of developing ADHD. And so that's what these percentages mean. And you know, you can look down and see, you know, the different variations. Everybody's got this increased risk. So it doesn't mean that it's definitely going to happen, but it's something to keep an eye out for, and you may already be experiencing some of this. So how do we generally treat these things? I'm not going to talk too long about medication. I think medication is a great intervention for a lot of kids. It can be really helpful. So just want to put that out there before I dive into a little bit of a critique of it. The stimulants, and I've given you some brand names here that you may be more familiar with than the generic trade names. The stimulants are, you know, quite effective for some kids, but overall, on average, we see pretty modest symptom improvement. So to give you a comparison, in psychotherapy, we see anywhere from 50 to 60% of kids who get significantly better, whereas with the stimulant medications alone, right, no concurrent psychotherapy, we see about 20 to 23% of kids who improve on those medications. So by comparison, it does seem like psychotherapy tends to be more effective, and certainly for a lot of kids, stimulant medication combined with psychotherapy is even more helpful. The antipsychotic medications also account for a huge proportion of use in children with disruptive behavior problems. Some of the limitations with the antipsychotics, although they can be quite helpful, I've certainly had kids in my practice and in our research who have done really well on these meds. There are some pretty significant side effects that you have to keep a close eye on. And families from low socioeconomic backgrounds and families of color are also much more likely to be prescribed medication. This has somewhat to do with Medicaid reimbursement rates and some also kind of institutionalized barriers to adequate care. But what we know is true is that the medications don't help us address underlying deficits in emotion regulation, right? They're just not capable of doing that. It'd be great if they could. So psychotherapy interventions for disruptive behaviors are generally behavioral, or they have historically been behavioral and directed at parents. So if you present for treatment, you're going to be, you know, give some information, background, and then typically the therapist is going to say, okay, let's work together with you. So the therapist will do some coaching and help parents kind of figure out how to change the cycles of reinforcement that are happening in the family. They're pretty time limited, and they focus on the function of the behavior. So how did these behaviors emerge within the family system, and how are they maintained? And they are quite effective, but they do not adequately address, at least in my opinion, and I think what the research also suggests and supports, underlying emotion regulation problems, and they definitely are not interested in kind of understanding the meaning of the disruptive behaviors. So here are some names. These are kind of brand names for the behavioral parent training approaches. So if you are thinking maybe you do need treatment or your child would benefit from these types of interventions, these are the kinds of things you want to be looking for. And these would mainly be interventions that would work with you, not directly with your child. I'm going to skip this, but that will be available on the YouTube channel if you want to go back and look later. So one of the basic premises that underlie the behavioral interventions is coercion theory. So the idea is that problem behaviors get reinforced in the system. So think about like an incident in your own home, right? Your kid's throwing a tantrum, your kid's refusing to do their homework, whatever. They're causing a scene. And so you threaten a consequence. All right, you know, you're going to have this punishment. You're going to lose screen time. You're not going to have dessert. We're not going to go to the pool, whatever. And the kid is like, okay, no, I'm going to keep having the problem behavior. And so you up the ante. You've got another consequence, or you say the same consequence over again. And then that doesn't work, right? So there's more defiance. And then what do? We give up. with surrender. And it's like, oh, fine, let's just move on. And then everybody's calm. And so this is a really common pattern. I do this with my kids. Everybody does this to some extent. And, it's not great, but we all fall into it. But when your kid is presenting with really intense disruptive behaviors, it's even easier, right? Because you just want to keep the peace. So the behavioral approaches work to kind of change this coercive cycle. So here's how the child-driven cycle works. Child makes a demand, the parent says no, the kid throws a fit, the parent gives in, and now the child has reinforced the parent, right? If you give me what I want, I'll stay calm, right? If you give in to my demands. So we want to try and change that, and this is what the behavioral approaches would work to help you do. Child makes a demand, parent says no, the child argues, and then there's a withdrawal, right? We call this active ignoring or benign neglect, right? You stop talking, you don't engage, you remove the reinforcer. Your arguing is actually reinforcing. And then what in theory should happen is the child will calm down, stop arguing, you can then make a counteroffer, and there's some negotiation that can take place, and you stay engaged with one another instead of in a battle that's reinforcing negative behaviors. In a parent-driven cycle, the parent directs the child to do something, the child refuses, the parent increases the demand, the child argues, and then the parent gives up and backs off, right? And this just reinforces to the child, yes, keep arguing with me because it works. And so this is how you would break that cycle through a behavioral approach. This is how we all want to look, right, when we're dealing with these behaviors. This is what we aspire to. So the parent gives a directive to the child ignores it, and it's the same thing. You stop talking, you remove yourself from the situation, you remove the arguing, which is actually reinforcing. You might do a timeout, something like that. Eventually the child, in theory, will comply, and then you give lots and lots of praise, right? That was great, you're doing wonderful. One of the key phrases in behavioral treatment is catch your kid doing something right. Right? So you always want to be giving lots of positive reinforcement for the behaviors that you want to be seeing. These approaches, the behavioral approaches, are not just for kids. There's a great article I love by Amy Sutherland. You can look this up online. It's from 2006. And I think she also had a book that came out shortly after this article was published. But you can use behavioral principles on your spouse, your loved ones, to try and shape behavior through these interventions. So if you're thinking about someone with an XY variation who isn't a child anymore, maybe they're a young adult, maybe it's yourself, maybe it's someone that you're married to or in a relationship with, you can really use the same principles to shape behavior and break that coercive cycle. If you want to learn more about the behavioral approaches, there are wonderful books available. Alan Kasdan is really the pioneer in this field. Ross Greene also has quite a few books. The Explosive Child came out when I was training, actually, and I studied under Ross Greene, and we worked together to reduce restraints and seclusions at an inpatient unit at Cambridge Health Alliance, just north of Boston. And so these are really great resources that I recommend if you're just kind of getting started with thinking about how to change these cycles. There are some challenges, and this is where the work that I do has kind of come in, challenges of behavioral approaches. The therapies have pretty high attrition rates, so about 50% of families who start parent management training do not complete treatment. To train clinicians in PMT or behavioral parent training, parent management training is very expensive. So for example, to train 16 clinicians in one clinic, it's 1 year of training. That 1 year costs about $1.16 million, and no families are treated during that startup year. So if you think about clinics in your area or hospitals or private practices, right, very few people have those kind of resources to train their staff. So it's a little bit hard to find this treatment in usual care settings. We know that what we see in the lab doesn't always generalize out in the community. And the thing that I'm most interested in is the way that the behavioral approaches kind of fail to address the more implicit emotion regulation deficits that are central to these kids. So, and I'm going to introduce a different model a little bit later in the talk. So more contemporary models have really emphasized emotion regulation, right? We understand emotion regulation as a very primary mechanism for all sorts of distress. Anxiety, depression, disruptive behavior problems, substance abuse, you name it, emotion regulation is a key component. And there are some therapies like dialectical behavior therapy, which is primarily for adults who have borderline personality disorder or some risk-taking behaviors, emotion-focused therapy, which works with couples, and some of the acceptance and mindfulness-based therapies. So why? Why has emotion regulation become kind of all the rage? Why is it important? So we know that emotion regulation plays a key role in disruptive behavior. So this is a little complicated in terms of the stats, but basically what this is telling you is that we know that family negative emotions and family's acceptance of feelings are associated with aggression in children, right? So the more negative expression and the less acceptance you have of complex emotions, the more aggression you're going to see. However, the child's ability to regulate their emotions actually mediates this relationship. And so it can actually interrupt the relationship between these two variables and the outcome of aggression, which is a really important finding, and suggests that if we target emotion regulation, we could actually have some pretty great outcomes. We know that emotion regulation is associated with all these great things, including positive health outcomes and lower risk for the disorders that we're talking about tonight. So what is it? I keep talking about it. Let's define it. So emotion regulation has to do with both internal and external processes that help us initiate and maintain and modulate the intensity of our emotions. So it includes things like awareness and understanding of emotions, like can you name them even? Can you identify what you're feeling? Acceptance of emotions. Do you have to push aside what you're feeling, or can you say, well, I feel that and that's okay? The ability to control impulsive behaviors, especially when you're experiencing a negative emotion, right? If you think of yourselves like road rage, right? Somebody cuts you off, you're pretty angry. Are you able to control your impulsivity in that moment? How do you do with your own emotion regulation? And can you use a really wide range of emotion regulation strategies flexibly? This is one of the big challenges we see, particularly in the kids with XY variations. Another big component of emotion regulation is delayed gratification. And if you think about, kids and adolescents with XY variations, you know that this is sometimes a real challenge. There are two types of emotion regulation, and this may seem too, in the weeds, but it's actually very important. And I'll come back to this a few times throughout the talk. So there's explicit emotion regulation, right? So like coping. Where you say, you know what, I'm not going to think about that right now. I'm going to take a break from that, or let me think if I can consider this in a different way. Oh, maybe that person was acting this way because of whatever. So where you're talking to yourself, you're doing something very clear to try and regulate your emotions. Implicit emotion regulation is something that's automatic, often unconscious, and it's kind of hard to describe. Like you don't really even know quite how it unfolds. And what we know is that explicit and implicit emotion regulation capacities come from very different regions of the brain. So this is a little bit, what I want you to look at are, look vertically. So look on the left side first. These are what we know about explicit emotion regulation. So look at the different parts of the brain, right? These are the different regions of the brain that we know contribute to explicit emotion regulation. So that ability to talk to yourself, to restructure your thinking, a lot of what gets addressed in parent management approaches is explicit, if emotion regulation is addressed at all. Look over here, this implicit emotion regulation. These are very different regions of the brain. So I know this looks like it's close to this, but they're actually quite different regions. And this is very deep in the brain, the insula. And so when we think about designing psychotherapy approaches, we're really even thinking at a neurological level. What parts of the brain are we changing? What neural pathways are we trying to adjust and modify it through our approaches? So I'm actually going to go a little bit quickly through this. Upregulation and downregulation are just ways that we monitor and manage our emotions. This is probably the best example. So you think about yourself, right? You're feeling a little low, you're feeling these things. What can you do? You take a break, talk to somebody, ask for a hug. This is how you kind of get your emotions up and running. That is typically not the problem we see in kids with disruptive behavior problems, right? They tend to fall into this section. They need to down-regulate their emotions. Now, all of these tools down here, these are all explicit emotion regulation strategies. They're very concrete, tangible, easy to identify and access. And remember, we're going to talk a little bit more about the implicit emotion regulation. So how do parents help children regulate emotions? You can look at this list and think, I'm doing these things. Probably you're doing all of them to one extent or another. It's hard to do them all consistently because we're human. So you help your kid select certain situations. You think, oh, I know this is going to be a trigger. Let's try and avoid that. You modify the situation. You change, the stimulus and the environment. You help your child to shift their attention. You stay emotionally connected to them and attuned to what's going on with them. I remember in an early intervention report that came back about my son, they said something like, the mother reported that Urban was feeling tired, but this would not have been perceptible to anyone else in the room. It was really something that only the parents were able to be attuned to. And it's because we knew him, just so you just know your kid really well. He was a kid who didn't cry, didn't talk really at all, was very passive. But I could tell, when he rubs on his ear that way and he turns his head that way, that means he's tired. And so you do that too, I'm sure, with your own kids. These are harder, right? How do you stay sensitive? How do you stay soothing, particularly when you're losing your cool? And I'll give you some concrete suggestions about that in a little bit. Reflective functioning and mentalization. This is trying to help your child realize that everybody has different minds, that we all think in different ways and we feel in different ways. And then being a role model. How do you talk about your own emotions? Are you able to accept and identify your own feelings? It's hard to do. So it is just difficult to regulate emotions. It's really hard. Some feelings are harder than others. When I teach graduate students, I often try and take a poll in class and say, so for how many in the room is it easier for you to feel anger and rage than it is to actually get sad and feel really down and disappointed? And about half will raise their hands. Yeah, I'm good with anger. I got that down pat. And then I'll ask, and for how many of you is it really much easier to feel sad and you actually cry and get withdrawn when you feel angry, as opposed to yelling and stomping your feet? And about half will raise their hands. We're just better at certain modalities, and that may have to do with our own histories, how we grew up, our own temperament, our own genetic makeup. But, for a lot of the kids with XY variations, the former tends to be the case. So typically there's a kind of familial cycle of emotional dysregulation. And this really mimics what I showed you earlier about the behavioral approaches, right? Just as there's a reinforcement cycle for behavior, there's a reinforcement cycle for emotional dysregulation. And I think this image, though disturbing, kind of describes it really well. And I put works in quotes here, right? So it quote unquote works together, though dysfunctionally, in a dysregulated way. Because everybody's kind of gone from 0 to 60 so quickly. It's hard for anybody to pull back and get calm. So I'm going to talk specifically about emotion regulation in a few of the XY variations. Now, I do focus a little bit more on the Klinefelter population because there's just so much more research in that area. But as you're listening and you're thinking about your own child or thinking about yourself, just know that a lot of what we have found in the XXY research applies to the other XY variations. There's a lot of overlap. And in fact, some of the findings from the Klinefelter research apply to just kids in general with disruptive behavior problems. So we know that Klinefelter men tend to experience increased emotional arousal. They have a lot more difficulty around social cues and processing. some of the social signals in the environment. And you can imagine, right, if you're not picking up on kind of basics of social interaction, people are going to get annoyed with you. You're going to feel frustrated, and that's going to provoke its own kind of emotional dysregulation. We know that Klinefelter men have a harder time verbalizing and identifying emotions, managing intense emotions, and also assessing the trustworthiness of faces. And that's kind of a pairing of emotion regulation deficits and social difficulties. So if you look at these first two, right, you read this and you go, oh, that's emotion regulation difficulties. And so that's really key. This is a little bit of an older study, but it's so interesting. So in this research with the Klinefelter population compared to just sort of neurotypical, quote unquote, normal, I put that in big air quotes, population, they did a game. And the ultimatum game is where you say to the subject in the research, okay, I've got some money. I'm going to split it with you. In this case, it was, I guess they're using British pounds or euros. So let's say dollars, because that's easier for me. I've got $10. I'm going to give you $5, and I get $5. Okay, and so up here is the percentage of participants who say, yeah, okay, I'll take the money, fair deal, right? And then over time, the offers get a little bit more unfair. So here it's, okay, the computer or the other researcher, the researcher in the room says, I'm going to keep 7, you get 3. And you see the acceptance rates of that deal decrease, right? People are like, that's not fair. I don't want your stinking money. And then over here, this is where you see the responses start to diverge. So this is participants without Klinefelter syndrome, right? They're like, oh, okay, 50% of the time, you know, now we're at 8 and 2, and over here we're at 9 and 1. I get $9, you get $1. Still have 50% of participants without Klinefelter saying, okay, fine, give me the dollar. I'll settle for that. But what you notice here is that when the game gets really unfair, the participants with XXY are much more likely to say, nope, I don't want this deal. It's not fair. And so that's a real, if you think about how that might work in the job market, how that might work in love relationships, how that's going to work in the classroom or in after school activities, right? Where you're, all of these situations, you encounter things that are unfair. And so if you have these types of emotion regulation deficits, it's going to affect your decision making. This is a little bit of a repeat from an earlier slide, but the key here is looking at this decreased eye contact. And I'm going to show you an image of this in just a minute. First, let's talk briefly about empathy. So we know that it's a little bit harder for Klinefelter subjects to have empathy, particularly when it comes to emotions, but most notably when it comes to empathy for their own emotions, right? That's really an important finding. So think about if you're not able to have empathy for what you feel. We've all felt that way, right? Like, oh, I shouldn't be feeling this, right? It makes it really hard to kind of work through that feeling and proceed in a healthy, kind of resolved way. So that's something, you know, to take into account. This research showed participants a kind of emotional father-son scene, and what you're seeing here is eye contact. So this is a heat map of the participants' eye contact. So you see the control group, this on the left, this is A. These are people without Klinefelters, participants without Klinefelters. They're really looking at the boy's eyes. They're thinking, okay, this is a really emotional scene. I'm going to maintain my gaze, connect emotionally, and there's probably empathy being activated, all sorts of things. Over here, you have the Klinefelter sample, and you see that the eye contact is averted, the gaze is averted. They're looking a little bit at the face, but definitely not right at the eyes, and there are even gazes over to the hand, down to the neck. And this is suggesting that there's some kind of discomfort around intense affect or emotion. And you may have experienced this with your own child, right? How do they respond when they've got an intense feeling? They break eye contact with you. Maybe that's because they need to. Just briefly, we have really similar findings, as I mentioned, in all of the XY variations in terms of emotion regulation and risk of disruptive behavior. So the emotion regulation deficits, I realize now I'm kind of missing a couple bullet points here, but just know that the emotion regulation deficits that I just talked about for Klinefelters are pretty common across all the XY variations. There's some variation in terms of intensity and prevalence, but generally speaking, it's consistent. Another thing we know is that speech delays are really almost ubiquitous in the XY variations. And one key component of emotion regulation is private speech. So, talking to yourself, sort of saying, oh, it's going to be okay, you're going to be all right, that sort of thing. And the question this raises is, how do children with XY variations create that nurturing inner voice, that compassionate, empathic voice when they don't have the words, right? When there is this speech delay? And this should say, oh, okay, I'm using you to refer to folks with XY variation. So how do children respond to a parent's intervention around emotions, which is often verbal, right? We talk to our kids when they struggle with expressive language. This is going to be a challenge. I think most of you are familiar with the research limitations with the sex chromosome aneuploidies in general. For the sake of time, I'm going to skip through this slide and just go on to talking about implicit emotion regulation. So this is revisiting that earlier slide. I just want to come back to it quickly, remind you that there are different regions of the brain that are activated when implicit or explicit emotion regulation is taking place. So in order to address the implicit emotion regulation capacities, I, with two of my colleagues, Leon Hoffman and Tim Rice, designed a new psychotherapy intervention that really focuses on understanding and enhancing implicit emotion regulation. This is a play therapy intervention. Right now we work with kids who are ages 5 to 12, and it maps onto the National Institute for Mental Health's neuroscience framework, where they identify different regions of the brain and talk about how child and adolescent behaviors are related to those regions. The treatment is also very easy to train people in. It's a relatively short and cost-effective training process. Right now, the people who conduct the therapy in our research studies are all second, third, and fourth year graduate students. So it's not like you need to have decades of training in psychotherapy, which is really what we wanted, because we want this to be really portable. We wanted to call the book, Why Is It Easier to Get Mad Than to Feel Sad? But unfortunately our editors nixed that. So when kids come into our lab, they kind of look like this. You guys are probably familiar with these presentations in your own home. But our conceptualization is that what's going on when you see this is that this is a cover story for this. That underneath this explosive behavior, there's more to the story. There's more going on. So these disruptive behavior symptoms occur because there are deficits in the child's ability to regulate their emotions. And the disruptive behavior is actually an implicit strategy, a coping mechanism that helps protect the child from painful emotions. It also protects and distracts parents from asking about or talking about those more complex, more difficult to manage emotions. And I've listed some of them down here. As I mentioned before, the implicit emotion regulation capacities are less conscious. They're often used without intention. They're involuntary. So when you see your kid go from 0 to 60 with that disruptive behavior, and you're kind of like, where did that come from? And your kid can't identify it, I don't really know, right? That's an implicit emotion regulation strategy. You may have heard the term defense mechanisms, right? We get defensive, that sort of thing. So defenses in general can be quite helpful. They help us cope. They help us manage anxiety. They're relatively automatic. They get kind of activated without us even being aware of it. And they help us avoid difficult feelings. The problem is those underlying feelings that are difficult, they continue to have a strong effect on us and on kids with XY variations. So the common defenses we see in kids who present with disruptive behaviors are these. Identification with the aggressor refers to, I'm being bullied, so if you can't beat them, join them. I'll just kind of be like that, even if the child can't articulate that. Projection, which is, accusing someone else of the feeling that you have because you can't accept it in yourself. So the other night I got into an argument with my daughter and I wound up yelling at her, stop yelling! Right? I was the one yelling, not her. That's a great example of projection, and I sort of chuckled at my inability to regulate my own emotions in that moment. Denial, right? This is a common one. I didn't do it, didn't happen. And projective identification is a little bit more of a complex defense mechanism, but I'm sure it's one that you're all familiar with. What happens is the child who is really dysregulated, they're feeling shame, they're feeling sadness, they're feeling something that they can't tolerate. So they act out, they have this disruptive behavior, and then afterwards, you're the one who's left feeling sad, ashamed, regretful, right? So it's a way of taking your own feeling, projecting it into another person so that the other person has to process it. It's no longer, you know, on your docket. You kind of dodged having to deal with it. Here are some more defenses, and I'm going to have this be available in the YouTube talk, so you can come back to it later. I don't know that we need to go over each of these now, but these are just definitions of some defenses at work. And these are things that we really focus on in our treatment with kids. So in RFP-C, as I mentioned, it's a play therapy intervention, and the key components are we want to understand what are the emotions that are being avoided. We want to work on describing them, both to ourselves as clinicians and to the parents and to the child. And the key thing is we want to understand, why did those emotions need to be avoided? Why are they so painful? Why are they so intolerable? And try and help kids deal with emotions better, those that seem very threatening and difficult. I'll give you an example. So in treatment, you have a kid who starts yelling, or this might happen at home, right? This game is stupid. I hate coming here, right? This is something that happens in my office frequently. So we understand that there's meaning to this disruptive behavior. The child's not being bad. It's not even necessarily about a coercive reinforcement cycle around behavior. This we understand as a defense. What is it protecting the child from? Some kind of feeling. So in this case, this child had just started talking about their parents' divorce. This provokes all sorts of feelings, as you can imagine, feeling angry, feeling sad. And for some reason, there's an inhibition around those feelings. I shouldn't be feeling this. I shouldn't be thinking about that. And that anxiety and inhibition gets overwhelming, becomes unmanageable. And so then you see this, right? This defense, this acting out behavior. And so big picture, in RFP-C, we think about how does the behavior mask an unpleasant emotion? We always are implicitly communicating the behavior has meaning. The child is not bad. They're not just trying to mess with you or manipulate you. We want to really get a better sense of what are the emotions that the child is avoiding and try and understand why that emotion needs to be avoided. So sometimes parents will ask us, you know, why do I need to understand all this? This feels like a lot of work, and maybe I'll never fully get to the bottom of it. So without understanding how children protect themselves against awareness of painful feelings, it's pretty hard to help them adapt successfully. So it is actually pretty key that we get to the bottom of this kind of triangle of conflict that the child is experiencing. So in using some of the RFP-C principles at home, and just to back up a second, I showed you an image of our book earlier. We do have that book out. That book is written primarily for clinicians. However, I assign it to first-year graduate students, and they all report that it's pretty easy to understand, pretty easy to take in, and these are people who have relatively limited psychotherapy training at the outset. So we're still working on developing a book for parents and teachers, but in the meantime, you know, the clinical manual may still be useful for you as you think about how to implement some of these things at home. So we always acknowledge that these outbursts are really difficult. I know for me as a parent, they're very difficult. For the parents I work with in my private practice office and in our clinic and in our research studies, it's hard. You get really dysregulated. So in the moment, we really encourage parents to know this is going to pass, right? This huge explosion, your child will get over it. Sometimes they get over it more quickly than you expect. You are definitely going to burn inside, and that's okay, right? We're not trying to get rid of that. And we're trying to help you think about how to accept that, to acknowledge it, to learn to tolerate it. That's okay to have those really angry reactions. You and your partner really need to be on the same team, trying to think about, you know, how we're going to respond, how are we going to work together to kind of introduce more emotional regulation for our child and for the family, and make sure you're taking time to reflect on the situation. So in reflecting, you want to think about, well, what does happen? When does it happen? Where does it happen? And this is slightly different than what happens in behavioral modalities, right? These are similar questions to what are asked in the behavioral interventions, but we're asking parents, and we work with parents to try and think a little bit below the surface. You know, what might have been on your child's mind? Okay, here's what was happening on the surface. What was happening underneath? Let's think a little bit more. Later, right? Later is when we ask the questions, why does it happen? And we want to try and get at this both from the parent's perspective and the child's perspective. So we're emphasizing actually passivity over activity. So thinking and understanding are actually more important than the specific action that you take in that moment. Initially, the key is to get a handle on what is the meaning of these behaviors. Why does the child need to engage in them? Children are oppositional for a whole host of reasons. They might feel frightened, they might feel vulnerable, angry, they feel like it's the only way to get the attention they need. And to listen to what the adult is telling them is to admit defeat. Now, these feelings are even more powerful and enhanced among kids with XY variations because of the reasons I mentioned earlier. The deficits in emotion regulation that we know are key, issues around empathy, issues around social processing, and language fluency. Those are all going to exacerbate these kinds of feelings. These feelings sometimes create a need for oppositional behavior. This is a quote that I just love. It comes from a great book on parenting. And this is from a chapter, Kevin Meehan and Elizabeth Zick wrote this chapter on parental humility, and they're both clinical psychologists. And it's a great chapter about clinicians, right? So how to maintain parental humility even when you're supposed to be an expert on this stuff. So why do otherwise calm, regulated individuals lose it with their children? What is so dysregulating about being a parent? One of the byproducts of the deep attachments that we form with our children may be that they are able to stir emotions and block our thinking more than just about anyone else in our lives. We fall deeply in love with our children, and the difficulty is that love sometimes makes it hard to think. And when I read this about a year ago, when I first read the book, I really was struck by this. And this happens, right? I remember being outside of our local recreation center, actually with my daughter, who has neurotypical development, but she was having a big tantrum, big explosion, and a parent in the community said, and he was sort of kidding, the timing wasn't great for me, but he walked by and he said, oh, I thought you were an expert in oppositional behavior. And I thought, oh boy, I should keep a lower profile and not let people think that that's true. So it doesn't matter how much expertise you have, right? These are issues that we all struggle with. So questions to consider. What gets activated in you when your child or your loved one gets dysregulated? What feelings does it bring up? What does it trigger for you? And how does that sort of implicit activation impact how you respond, right? You're going to respond in the moment for all sorts of explicit emotion regulation reasons, right? You're angry, you're tired, whatever. But there's something else, right, that can get activated. Does what's happening trigger your own feelings of, not being a good parent? Does it activate your own ambivalence about parenting? Maybe you weren't sure you wanted to have this third kid, and now, this is bringing those thoughts and feelings to the fore. Does it tap into your frustration with all the systems that you have to interact with, the school system, the early intervention system, to think, nobody's helping us, and I feel really angry at that system. And so when my child acts out, that's what gets pulled up for me. These are really important questions to think about, because they can help you respond differently to your child, can help you get a window into what are those underlying feelings that your child or your partner with an XY variation is experiencing. So go back to what I said earlier about projective identification, right? You're getting sort of a broadband, I guess FiOS now is the new thing, right? You're getting FiOS access to your child's inner experience. They're sharing it with you in this kind of maladaptive way, but it's good information for you to have. So as I mentioned before, you can pay attention to what's happening in your own mind. You can be very curious, maintain a curious stance. Think about your own feelings, your child's feelings. In the book, and you can also just use it from the slides, you can draw your own RFP-C triangle and kind of map out for yourself what do you think is going on for your child in a specific incident. We've run parenting groups in the past where we use those triangles in a group setting. And they're extraordinarily helpful, just a way to kind of conceptualize what's going on. If the disruptive behavior has meaning, if it's not just a byproduct of behavioral coercive cycles, I think that changes our response, right? It changes our attunement, the emotion that we bring to the situation, the way that we understand the function and meaning of the oppositional behavior. So you want to see yourself from the outside in a reflective way, and you want to see your child from the inside, what's going on inside, underneath. Reflective parenting doesn't mean perfect parenting. So here's a great quote. This is from Arietta Slade's wonderful article on parental reflective functioning. Sometimes she gets, as the mother talking about her child, sometimes she gets angry and frustrated in the ways I'm not sure I understand. She points to one thing, I hand it to her, it turns out that's not really what she wanted. It's very confusing. I'm not sure how she's feeling, especially when she's upset. Sometimes she'll want to do something and I won't let her, and she'll get angry. I try to pick her up. She didn't want to be picked up because she's in the middle of being angry and I interrupted her. In those moments, it's me who has the need to pick her up and make her feel better. So I will put her back down. Right? This is a really reflective parenting. Here you see that she's highlighting the child's mental state. She's recognizing that her child's mental state is relatively opaque. It's hard to get access to it. Again, with the opacity, it feels confusing to me, right? She's able to say, I don't really know what's going on. I feel confused in my own mind. She identifies a trigger for when her own parental emotion regulation decreases, when my kid's upset. She gets saying she'll get angry. She recognizes that her child has a different emotional life than she does. This is great mentalization. She recognizes that her child's intense emotions has an impact on the relationship and what her child needs in the moment. And here she's able to say, oh, there's something in me that's getting triggered from this behavior, and my needs are not in line with my child's needs, and so I do something differently. Right? This is a great example of how to reflect on what we do in these intense moments and how to do it in a way that is a little healthier. So if we understand disruptive behavior in terms of emotion regulation, which is very different, right, than just thinking about it behaviorally, or thinking about something underlying, it allows us to respond a little bit more empathically. So how can you foster emotion regulation, right? Get started early. You can work on building your secure attachment. That means that you're not just physically present, you are emotionally present. And of course, none of us do this perfectly all the time. But the idea is, to show interest, to show curiosity, to be attuned, trying to understand your child's behavior in terms of their mental states, right? Meaning there's emotion underneath there. Let me try and figure this out. Talk about feelings all the time. I think my kids think that every person is a feelings doctor. When I ask them, do you know what so-and-so's mommy does for work? Or do you know what so-and-so's parent does? They always say feelings doctor, because somehow we have lots of therapist friends in our lives. And we talk about feelings all the time. And of course, there's an app for that. There's a great app available for a variety of platforms called Mood Meter. And I know in my daughter's classroom, they actually use a mood meter in the classroom where kids can put a magnet on and say, here's what my mood is right now. Here's an example of one. This one's a little bit intense with all the colors and faces, but it's helpful for young kids. So mood meters usually map energy versus pleasantness. And it's usually on 4 quadrants. So low energy, very unpleasant. This is depressed. Very high energy, but still very unpleasant, enraged. Very high energy and very pleasant, ecstatic. Right? This is the kind of manic, over-the-top joy. And then very pleasant and energy is so low, is serene. And sometimes that's what we wish for in our homes, right? Another way to build emotion regulation capacities is to keep this acronym in mind. This is RULER, so to recognize emotions, to understand them, to label them. This is really key to do this as much as possible. Sometimes kids can get really irritated if you're labeling their emotions all the time. So what you can do is label your own. I'll give you an example. Our dog, we had to put our dog to sleep about a year ago, and I was very devastated, very upset. And I came home, my daughter said, Mommy, you are feeling sad, and it's okay to feel sad. And I thought, oh my goodness, this is like a major parenting victory. I feel so proud of myself. And I was crying maybe about 60 seconds, and then she patted me on the back and she said, that's enough, Mommy. Time to feel better. And I thought, oh, okay, still more work to be done. But, you know, to do these kinds of things, express your emotions, demonstrate how you regulate them. You know, maybe you're in the car and you get pissed off at another driver. You can say, oh gosh, I feel so frustrated by that. That made me so mad. And talk about, what are you doing to calm down? This is, you know, what we see as kids get older. A lot of, maybe even the young kids too, the I hate you, please love me. By using some of these explicit emotion regulation processes, you're also fostering implicit emotion regulation. Here's some recommended reading for the implicit emotion regulation piece. So the books I recommended earlier were for parent management training, behavioral approaches, and more explicit emotion regulation. This is actually a kit for really young kids, just to start with a mindfulness practice and thinking about how emotions manifest in the body. This is a great book about reflecting on ourselves and thinking about how our own histories impact the way we parent, what triggers us. And these are great. This is basically the same book, but for different age groups. This is some feedback from participants in our research studies, and this is really like what gets me to work every day, is this kind of feedback. I'll just read you what one of our little guys wrote. I wrote this card to thank you for all you did to help me. I am really happy because now I don't do tantrums that much anymore. This was such great feedback, better than all of the study measures that we do. This is just a basic summary. I think I've said all of this already. This is our research team. These are my collaborators, Dr. Hoffman, Dr. Rice. These are my fabulous research assistants, without whom none of the work that we do would be possible. I am so grateful to them. This is the scene that we're really trying to prevent. Some of you may have experienced this before, getting called into the principal's office. So we want to stop this. And if you want to learn more about RFP-C, we have a great website. It's mobile friendly. You can check it out on your phone or online. And that's it for today. I'll be happy to answer any questions you have. And I have extra slides too if certain questions come up that maybe would be helpful to look at some other data or other images. But I'll turn it over to Ginny.
Okay, well, actually, we have quite a few questions that have come in. The first one is, any suggestions to help with an adult kid?
Yeah, so I thought about that as I was making this presentation, you know, how to be all things to all people. So I'm glad that question came up, because I had some thoughts about addressing that, but I knew I probably wouldn't have enough time in the actual presentation. So it really depends on what age range you're looking at, but let's start with like young adults, like 20s. I would recommend a few things. I would say I'm glad that I at least included that Shamu article. That's a great one, just to get you started. And her book is also quite helpful. She's focused more on intimate relationships with a partner, but basically all the principles are helpful for really any, you know, relationship with a family member. So from a behavioral perspective, I would think about using some of those strategies. You know, not engaging in some of the more, you know, disruptive or difficult behaviors, making sure you take a break. And then for the implicit emotion regulation piece, definitely my #1 recommendation is to have that person go to therapy. And I know that has its own barriers, you know, time, money, energy, motivation. But individual therapy is really a great starting place. Usually, folks who have difficulty regulating emotions on an implicit level come to treatment because they want help with all the difficult people in their lives. And so that their sense is that everybody around me is causing me difficulty. Can you help me get along better with these difficult people? And that's fine, right? That's a great starting point for therapy. It's not uncommon that people come to treatment with that perspective. So definitely encourage therapy. I would encourage, thinking about your own interaction with the person from a behavioral perspective. And I think a lot of the things that I talked about in terms of self-reflection and thinking about what gets triggered for you in these interactions and modeling good emotion regulation, I think it still applies to young adults. But I'm happy to answer follow-up questions about that if there are any.
What is it about XY variations that predisposes kids to anxious or disruptive behaviors? Why are they at greater risk?
This is a really difficult question. I think it's one that we don't really have the answer to. I think people like Judith Ross and Nicole Tartaglia and some others are really starting to do some groundbreaking research looking at the neurological correlates and predictors for these populations. And I think a lot of those answers are still yet to come. I know there have been a couple papers published on eye gaze, so your ability, eye gaze, like what I showed you in that earlier image of eye contact with an emotional scene. That's sort of where the research has started, and also looking at things like cortisol levels. That's a stress hormone that we can test using saliva. But we suspect that the reason has to do with really fundamental neurological differences. Unfortunately, that research is really expensive to do. Yes. And hard to get funding for. So we're, kind of at the beginning.
Well, I know that there's a long-standing study that is gone on at NIH. It's the neuroimaging. Mm-hmm. And in fact, years ago, my son participated, I think, 4 times in that. And I know that they're trying to correlate differences in the size of brain structures, mm-hmm. Particularly, I think, the amygdala.
Yep.
With arousal difficulties, with the various things that you're talking about. But at this point, they still have not done enough neuroimaging studies to have anything that's definitive.
Yeah.
So it certainly helps. Yeah, it certainly helps if people go to the research tab that Access has. And if you're interested, NIH pays almost all the cost of the transportation and housing for a child and a parent. And I believe that this is continues to be a serial MRI study. So about every 2 years, the children will go in.
Mm-hmm. Yeah, and I just want to echo that. There are a lot of great research studies on the Access website, genetic.org. I would encourage as many of you as possible to just look at those. I know we're going to be participating, I think, in the Trixie study soon. It's just really, really important research, and a great way that we as parents and families can give back and contribute to more knowledge in this area.
Okay, I have a question. Is oppositional defiant disorder the same as pathological demand avoidance? PDA is recognized in the UK, but as I understand, not in the US. We must have a questioner from the UK. It's considered part of high functioning end of the autism spectrum. Our 14-year-old 47XXY was just diagnosed with autism last year. I'm also wondering if autism is a common comorbidity with Klinefelter. I can answer that. It's about 20% of the kids with Klinefelter syndrome seen clinically also meet the criteria for autism.
Mm-hmm. And Jenny, can you say that name again? Pathological
Pathological demand avoidance, PDA. I don't think it sounds as though PDA is the same as ODD.
Interesting. Yeah, I'm not familiar with that. So the diagnosis of ODD and ADHD, all the other disorders that I mentioned in the talk today, come from the Diagnostic and Statistical Manual, which is in its 5th edition now. It's called the DSM-5, and that's published by the American Psychiatric Association. However, it is the universal diagnostic manual globally. It just helps give clinicians like a common language to communicate with. So PDA may be a diagnosis that is new or just not recognized by the broader establishment. It's definitely not one that I'm familiar with, so unfortunately I can't comment on it specifically. But I think there was a question in the middle there, Ginny, about ASD being comorbid with ODD. Yes, there is. That's a complicated question. So a lot of times we'll see kids come in diagnosed with autism spectrum and ADHD, or autism spectrum and ODD, or all three. And while that is possible to have all of those disorders, it's rare. I think what usually happens is we try and whoever's doing the diagnostic evaluation tries to account for all of the symptoms. And so they will provide a lot of different diagnoses when in fact the ASD may actually account for some of the attention issues or some of the compliance issues. Sometimes that's done for insurance reimbursement purposes or just not a thorough enough diagnostic evaluation. In our research, we do, our evaluations are really long and intense. So they're like 2 to 4 hours. We meet with the kid, we meet with the child, we meet with we get feedback from the teachers. It's a lot of data that we get. And we actually don't take kids into our research study right now who are on the autism spectrum. We certainly hope to in the future, but just to start out, we're not able to take those kids.
I have a question from a mother of a 9-year-old. She's describing a child who hits, punches, curses, including racial slurs, and then the child feels guilt, remorse, and grief. How can mom forgive and console without reinforcing this bad behavior?
Oh yeah, that's an interesting. Okay, so the mom is saying, if I help with the guilty feelings, then maybe I am somehow sanctioning the behavior, right? That's sort of what the question is getting at. Yeah, I think it depends somewhat on the child's verbal abilities and self-reflection ability. So my answer, I guess, would depend a little bit on the specifics of, a particular child, which I want to maybe not get into tonight, but I can give you some examples. So let's say a kid who really gets, what's going on, a kid who can say, look, I don't want to do these things, but when I lose it, it's just kind of these things fly out of my mouth and I really, lose control. I don't know why. And then I feel so guilty and nothing makes me feel better. A kid who's quite reflective in that way, even though they're not well regulated, I think that kind of consolation and comfort is not likely to sanction the behavior. It's not likely to say, you're not implying like this is okay. You're saying, look, that behavior is not okay. It's not acceptable. But I also see that you're really suffering and you feel really bad. I think in that situation, one thing that would be universally helpful, regardless of the degree of reflective capacity on the part of the child, would be out of the moment, so not when all of this is going down, later, at a time when it's possible to talk in a rational way, for the parent to give some examples of when they've been dysregulated and then felt quite guilty about that. Certainly age appropriate, don't overshare, but something within reason to say, something like that happens to me a little bit, and here's how I've dealt with it, here's how I've thought about it. You could also do some play, so playing with dolls, playing with action figures, and kind of playing out some of these scenarios, and having your child do some perspective taking in that way. Be the person who's the character who's getting hit, be the character who's acting out, be the character who's observing the scene unfold, to help activate some of their perspective taking capacities. And therapy, definitely would encourage you to pursue that.
Okay, I have another one. The research findings regarding gaze aversion seem similar to findings in children with ASD. Generally, there seems to be overlap with the presentation of Klinefelter syndrome and other neuropsych disorders. Is there any research to suggest that boys or men with XXY are missed for dual diagnosis? I'm not sure quite what that means.
That maybe they get labeled as XXY and then the ASD doesn't get treated because I think it's more likely to go the other way.
I think it's more likely to go the other way as well, that there are many kids walking around with autism diagnoses who actually have an extra X or Y chromosome, but because they don't look syndrome-y, they don't get tested.
Yeah, and Ginny, you've had a lot of experience with that, right? I mean,
yes.
Being able to identify that.
I worked in a developmental disabilities and autism clinic, and in fact, when I finally convinced some of the clinicians to start doing karyotyping, we found, I believe, 7 children with extra X and Y chromosomes in a group of about, I think it was 280 children who were diagnosed with autism.
Wow.
But we only did that because I started pushing it, and then we got a new psychiatrist who thought that there was some, that there was certainly a reason to be looking for genetic conditions. Mm-hmm. We also found other genetic disorders like Williams syndrome. But the most common genetic disorder that we found were X and Y variations. I've got another one. My son is 20 with XXY, and we've had our fair share of emotional regulation problems. But thankfully, things have been improving with continuous use of some of the strategies that you outlined. But one thing that keeps coming up when the facts of him having when the facts of his having XXY is mentioned, his response is always, "Why do you have to remind me that I have all these problems?" He's been very resentful whenever I bring it up and resistant to talking about it. I don't want to dwell, but I want him to become comfortable talking with us about this. Do I push it or just wait until he approaches us with questions, even if it's when he's 30?
I think you wait. Yeah, I think it sounds like this parent has done a really good job, introducing it, saying, I'm willing to talk about it. I'm available, for questions. I think there's a limit, to how much you can push before you, push away. Yeah, I don't know that much would be gained from continuing. One thing I might say, if it came up, and a young adult was, frustrated, why do you keep bringing this up, or why is this all about my problems? I think what I might do is what we would do in RFP-C is kind of join with the defense. I think that's a defense against whatever feelings he has underlying about the XXY diagnosis, right? What does it mean? What, even in his response, he's saying it's a problem. You're trying to say I have these problems. So there's some negative, association with it, which is understandable. But I would kind of comment on that and say, oh yeah, it makes sense you don't want to talk about it. It's uncomfortable. Mm-hmm. I would really kind of emphasize that, because you're highlighting that there's something going on underneath. You're highlighting that he's avoiding it. and you're being very empathic and just saying, yeah, this is really hard stuff to talk about it. I hear you.
Mm-hmm.
I get it. You know, maybe we don't need to talk about that right now. You're letting me know that it's too much.
And I think that sometimes the children, generally teens, have a very difficult time talking with their parents about this particular genetic condition. Mm-hmm. What they do seem to really like is going either to attending support groups where there are peers, or attending the conference and just being able to hang out with other young people who also have extra X and Y chromosomes. Mm-hmm. They spend most of their time socializing, I've observed. They might spend some time talking about the extra chromosome and, you know, implications in their life. But I think that they get much more comfortable with it when they simply hang out with others who've got the same thing.
Yeah, and I was so impressed at the support group meeting we had in New York. We had a couple kind of young adult guys there, and I just thought, oh, this would be so great for someone even younger than them to hang out with them. You know, they're cool guys who can talk about it a little bit, but can also talk about all sorts of other things.
Yes, right. I have another question. My son only just started testosterone therapy at 17, so this is a big difference for him. I feel like he needs a therapist to talk to as the testosterone levels in his body rise. It's made a huge difference in how he responds to situations. I see a difference depending on where he is in the month between shots. How do I address that? How do I find the right modality of therapy for him? And more to the point, how do I find the right therapist for him?
Oh gosh, finding a therapist. I say that in complete empathy with how hard it is to find the right fit. So I think I would start with the provider who is providing the testosterone. So particularly if they are somebody with specialization in XY variations, it's likely that they have some good contacts for psychotherapists who are also familiar with the genetic condition or the biological implications of monthly testosterone injections. So I would start there. You could also, and Ginny, maybe you can jump in on this. I believe there are some providers listed on the Access website. I don't know if there are mental health providers.
We don't have a lot of mental health providers. We really need more. We tend to have endocrinologists. But one of the a month in between shots is a long time. And so you may be seeing quite a roller coaster. I think that it's generally thought that 10 days to 2 weeks is probably, it may be a better interval. Or looking into gel that's applied daily, and then you get rid of the roller coaster. So there are other kind of modalities. There are also different dosing schedules. But I'm looking at this month in between shots, and I think that most of the people who are in the clinic consortium would not recommend going that long between shots.
And now just say one more thing about therapist selection. You know, I know when I meet with new patients in my practice, particularly teenagers, you know, I tend to meet with the teenager first to form an alliance and say, you know, you're my patient, not your parents. I'm here to help you. And then I say, you know, I'm going to meet with your parents. Here's what we're going to talk about. And I always tell teens, you know, look, let's meet 2 or 3 times. You get a feel for what it's like to work with me. I get to know you a little bit. And then we can decide, is this a good fit? Or do you want me to give you some suggestions of other folks that you could work with? And, you know, no harm, no hurt feelings, totally fine. And so whoever you seek out for therapy, you know, I would make sure that they're open to that. You know, you may have to try out a couple providers until your son feels more comfortable and finds the right person.
Are there any games or engaging ways to teach your child how to better recognize social cues?
Yes, there are so many good games. Great question. Let's see there. The first one off the top of my head is the thinking, feeling, doing game. It's called the thinking, feeling, doing game. And that you can get that on Amazon or wherever. It's very widely available. And I'm actually just looking up because I can't remember off the top of my head. There's another great game called What Do You Say, What Do You Do? And there are different versions of it. There's what do you say, what do you do at school? What do you do, what do you say, what do you do with friends? And that's a social skills board game. And then there are also these little, what are they called? Little jars of questions. Oh, that I'm kind of blanking on right now. Oh, here, table topics. These are teen, that you can get them for teens, you can get them for slightly younger kids. It's called table topics. And those are questions to start great conversations. And they include, you know, questions like, what would you do if this happened? And they're kind of non-threatening. There's also some like silly questions, you know, what's the scariest movie you've seen, that kind of thing. And then on top of that, basically any competitive game is teaching social skills. So if it's a game that has winning, losing, turn taking, the ability to cheat, all of those things, even better, that's all social skills training right there. And the idea is not for your kid to do all those things right? Like you know, 6, 7, 8-year-olds, they should try and cheat in a board game. That's totally age appropriate and normal. But can they joke about it? Can they think, you know, admit it? Can you be playful with them about it? So it's all about also, you know, your own competitive feelings. Interestingly, we have a big section in our book about that, about how therapists get competitive in play therapy and what they can do to not get so competitive. That's a great question.
Okay. Is there a way to search therapists in our area that are trained in RFP-C?
Oh, unfortunately, no. Right now, we only have therapists in New York City who are trained. If you're in New York, yes, please. We would love to help you. We are just launching like an online training platform where we'll be able to train more therapists more broadly. That's hopefully going to start in the fall. But that said, you could, for example, like the website Psychology Today has a therapist finder service that I think is quite good. And you can put in a variety of criteria, like the age of the patient, your insurance information, your zip code. And I believe you could search by keywords, and you could search for emotion regulation. Those would not be therapists who are trained in RFP-C, but they at least have some awareness of emotion regulation. Or you could search by emotion focused therapy or affect phobia therapy. Those are two possibilities where you might come up with someone who has similar training, though not the exact same thing.
Okay. My son never thinks that he's done anything wrong, and whatever the problem, he justifies the problem by finding fault with others. What suggestions do you have for trying to get him to be more responsible in interacting with the family? He apparently has a lot of difficulties with his brother. So,
does it say if the brother's older or younger?
I think the brother is a twin, so they're the same age.
Oh, same age. Okay, got it. So definitely lots of fuel for competitiveness there. I am guessing that this parent has tried all sorts of things already. And probably the one thing that he or she hasn't already tried is more of a meaning-based approach or emotion-focused approach. So typically this happens all the time. This is like every 5 minutes in an RFP-C session. You know, we have kids like break stuff, they run out of the room, they destroy things, they start screaming. and then they deny that any of that happened, you know, or the toys do bad things and they say, oh no, nothing happened. And our approach to that is, if you're thinking about what is the meaning of that behavior, you can very simply phrase it as, oh, it's easier to, you know, blame it on the kid who was here before you than to think about, you know, what's going on for you. Or it's easier to try and break the camera than it is to talk about how you're having a hard time at school. And there's no pressure there. I'm not, you know, I'm not telling the kid, oh, we need to talk about that now. I'm just noticing how this behavior serves a really important purpose in protecting the child from having to deal with more complex, painful emotions. So to go back to that idea that what you see on the surface, which is irritating and driving you crazy, is covering up for something that's going on underneath. So I would add that into whatever kind of behavioral things this parent is already doing.
Is there a relationship between emotional dysregulation and executive function? Can working on executive function help with ER?
Absolutely. Yeah, there's definitely a strong link between those two things. For those who aren't as familiar with executive functioning, it has to do with the ability to plan, the ability to use working memory, to have good processing speed when doing complex operations in the brain. And we see a lot of executive functioning deficits, particularly in kids with ADHD. And there's a well-documented research literature on executive functioning deficits in kids with XY variations as well. So yes, absolutely. Executive functioning coaching can really help kids, you know, plan better, think a little bit more long-term about consequences, think about how their choices now might impact other people. It's a little bit different than emotion regulation because it's not as introspective. It's more about changing how I behave in the environment and how I organize my environment. So it's not going to cover all of the emotion regulation bases, but it'll definitely have there will be a benefit.
Okay. Are you aware of any research on a relationship between emotional dysregulation and substance abuse in young adults?
Yes, there's a huge body of research on that. So generally speaking, we think about people who have substance abuse problems more often than not experience what we call alexithymia, which is just a fancy word for difficulty talking about feelings, inability to talk about feelings. And that's a really common issue in substance abusers or people who abuse substances. And that is because they're not able to regulate those emotions. And the drugs or the alcohol are the tool that they have that they're using to regulate emotions. So it's a way to medicate, self-medicate, when you don't have enough resources to manage those emotions. And so a good substance abuse program will both address the substance use and pursue increases in gains in emotion regulation and ability to tolerate emotion.
I have another question. What's the balance between a 22-year-old boy treating him as an adult, but knowing his decision-making is not like his chronological age? Well, we know that adults with X and Y variations frequently, you know, are emotionally not quite at their chronological age. Sometimes they're 4 to 6 years behind. But this mom is saying, but how do we do this without making him feel less capable?
And Jenny, can you tell if the question is about like how to interact with this young adult or how to get them treatment?
I can't really tell. It could be interacting with. It may be interacting with the young adult and having to provide maybe more direction than the adult wants.
Okay, so in terms of the interaction, I think there's no reason you can't just do, like, going back to that, not just for kids slide. You can do those kinds of behavioral interventions that you would do with an adult to shape behavior. And there's nothing really infantilizing about that. It's just a good way to have boundaries and interact with other people in your life, regardless of their chronological or developmental age. And then in terms of the emotion regulation piece, I basically do RFP-C with all of my patients. I also see lots of adults in my private practice. And, the same strategies and interventions are very similar. You can use them for adults, you can use them for kids. With adults, I'm just not playing with toys, but I'm noticing, how the person is protecting themselves from painful emotions, trying to help them increase their tolerance for those emotions. As a parent, you can always be modeling feelings and being able to talk about them, containing those feelings, providing attunement, just like you would with a partner. Hey, you're looking down, I wonder what's going on, I've been noticing this. And then in terms of treatment, sometimes family therapy is a great option, because then you're not saying, look, you have this problem you need to go get help for. You're saying, like, hey, we as a family could be healthier. We could work together better, and we're just as invested in this process as we hope you will be. But this is not about, like, you did anything wrong. This is about all of us just getting healthier.
All right. I think we are out of time. So I want to thank everybody for participating, and I particularly want to thank Tracy for this wonderful presentation.
Thanks so much. It was a great opportunity. I really appreciate being able to do it.
And this should be available on the website within a couple of weeks. We record all of them, so because there were so many wonderful resources that you provided that I want to go back and note some of them down. So
okay, great.
All right. Well, thank you very much to all the participants. Good night.
Okay, good night, everybody.